Foundation for Science, I am pleased to introduce the current webinar, which is devoted to epidemic risk trends after COVID-19. It will last from 3 p.m. to 4:30 p.m. This webinar will be hosted by Professor Arnaud Fontanet, who is well known by the listeners who have been able to listen to him numerous times on the various issues related to pandemics as part of SCOR Foundation webinars or SCOR Group workshops. We have been, of course, managing our best fruitful and stimulating partnerships with Arnaud and the Institut Pasteur, especially during the COVID-19, but not only. Professor Arnaud Fontanet is a French physician and researcher, director of the Center for Global Health and of the Emerging Disease Epidemiology Research Unit at the Pasteur Institute. Specialist in the epidemiology of infectious and tropical diseases, he is professor at the Collège de France, where he holds the public health chair, and at the Conservatoire national des arts et métiers. He is a member of the Scientific Council set up by the President of the French Republic, Emmanuel Macron, to assist the French government in managing the COVID-19 pandemic. Internationally recognized, Professor Arnaud Fontanet is one of the leading academic figures best placed to learn lessons from recent epidemics and to clarify trends in both the global risk of pandemics and the optimal means pharmaceutical vaccine, for example, and non-pharmaceutical interventions to prevent and treat this risk. Arnaud will give us first directional answers to our current burning questions on pandemics. Do we know all pandemics that may happen? To what extent are pandemics under control? Are pandemic trends stable, downwards oriented, or upward oriented? Should we fear a new pandemic wave in the 10 to 20 coming years? As dangerous or more dangerous than the COVID-19? How to best deal with pandemics? By anticipating them, preventing them, or by fighting them as soon as they occur with vaccine or without? What are the best means to fight them while relying on everyone's self-interested behavior until we get a vaccine, or by relying on overall lockdowns or targeted lockdowns? Can we reasonably bet on an accurate vaccine by anticipating them or by reacting afterwards to the occurrence of a pandemic, etc.? But I must not deflower this subject, which Arnaud treats brilliantly with a perfect mastery of the topic. Thank you so much, Arnaud, to have accepted to tell us the new after COVID-19 story of pandemics and environment. We are eager to listen to you. As per usual, the webinar will last 90 minutes maximum from 3 p.m. to 4:30 p.m. Paris time. If you have understanding questions, please ask your questions as you go during the presentation of Arnaud. For substantive questions and challenges, please ask them at the end of the presentation. Arnaud, you have the floor. Let us say for 60 minutes, less or more, depending on how much time you need. Thereafter, we will open the discussion with the audience and we will close the webinar when questions will have been exhausted, and at latest at 4:30 p.m. Arnaud, thank you so much. You have the floor.
Thank you very much, Philippe. My pleasure to be here with you. And as mentioned earlier, I think it's a good time to revisit the lessons from the COVID-19 pandemic. I mean, we are now 4 years into the pandemic, and also try to assess the risk associated with other what we so-called emerging pathogens in their capacity of driving us to a new pandemic. So first of all, let's look at what a pandemic can give when we get this what so-called perfect storm. Perfect storm means we had a virus, a respiratory virus, capable of hitting the entire planet. Why? Because we all breathe. And if you were dealing with a virus, for instance, that is carried by a vector, a mosquito vector, only the people living in the areas where the vector lives would be at risk. But here, when it comes to virus like influenza for flu or coronavirus for COVID-19, since we all breathe, we are all at risk of respiratory virus. If you get a respiratory virus circulating on the planet, if that virus has a certain lethality, let's say about 1% of people die. For COVID-19, it was 0.7%. And if you cannot control it, which was indeed the case for SARS-CoV-2, for the very good reason that the transmission of the virus starts before onset of symptoms. Therefore, all what we can do in terms of isolation and quarantine, which had worked previously with other coronavirus like SARS in 2003 or MERS in 2012, no longer worked with SARS-CoV-2, as people at the time you start to diagnose them, isolate and put in quarantine, have already transmitted the virus to others. And therefore, when you get a virus where everybody is at risk, with a significant lethality, and where control measures do not work, you have the perfect storm. So when it comes to figures, it's a bit difficult to have data going up to 2024. What I'm showing you here is the excess mortality that has been computed for COVID-19 by the end of 2022. And according to The Economist, there had been 25 million excess deaths worldwide during the first 3 years of the pandemic. You may be surprised that as a scientist, I'm using The Economist, but I have to say that the models they used are very much in line with other models which have been published. However, they are the only ones who give figure until the end of 2022. For instance, WHO stops at the end of 2021. There were at that time at 18 million excess deaths, so that the 25 million of The Economist by the end of 2022 is very plausible. It's interesting as well, if you look at France, we had 170,000 deaths which were related to COVID-19. It was 70,000 during the first year, 2020, 60,000 in 2021, and 40,000 in 2022. Many have said that, yes, indeed, those figures are large, 25 million excess deaths. However, these concern people that were very old. And for France, on average, people dying were 86 years of age. And indeed, this looked like an old age. For that reason, it's interesting to look at what has happened in intensive care units. And we had in France about as many people who died as people who went to intensive care unit, about 150,000 for the first 3 years of the pandemic. But those people who were admitted into intensive care units were on average 66 years of age. And these people would not have been saved had the intensive care unit been saturated. Therefore, when it comes to what this fuss you made about people who were 86 years of age and who died and would have anyway died a few years later, please remember that by controlling the circulation of the virus with different measures that I'm going to discuss later on, the people we saved were people who, when they had to go to intensive care unit, could be admitted because those intensive care units were not saturated, and those people were on average 66 years of age. It's also important to realize that if 25 million people died worldwide during the first 3 years of the pandemic, about as many were saved by the vaccine. The estimates of the number of lives saved by the vaccines are exactly in the same range as the number of people who died for the first 3 years. Long COVID, which you can see mentioned on this slide, is a complex disease which combines fatigue, extreme fatigue, troubles of memory, troubles of concentration, and difficulties of breathing. And people may have different, either more fatigue or more problems of concentrations or more difficulties of breathing according to the different people. In any case, I mean, these symptoms are lasting. Some of them have had them since they were infected first time in 2020. And by the end of 2022, Santé Publique France was estimating that 4% of the adult French population was suffering from long COVID. And that will result in absenteeism and certainly an important economical cost. The good news is that the longer we wait, the lower the intensity of symptoms. People tend to recover from long COVID. Those who were most affected were those who were infected in 2020 in March during the first wave. And we know now that having been vaccinated divides by 2 your risk of developing a long COVID. So it's really those who got their first infection at the very beginning in March 2020 who have developed the most severe forms of long COVID. Mental health, there were many reasons to believe that there would be an impact on mental health of population in relation with this pandemic. It starts with the anxiety related to the pandemic, but it also can be related to the long-term impact of the control measures, particularly when they lasted until 2021, for instance. When there were many observatories worldwide, which were put in place by psychiatrists, because they really thought that there would be a major impact of the pandemic on the mental health of people who were already sick, who had psychiatric disease, or on people who so far were healthy when it comes to psychiatric disease. Here, we actually had some form of surprise. 2020 particularly did not see much happening in mental health. And the interpretation that psychiatrists give, and I leave this to them because I'm not a specialist of the topic, is that in fact, to a certain extent, this form of cocooning effect of these lockdowns and people staying with their families and the world being put at still, if you want, may have been somewhat comforting for many people who had psychiatric disease. And therefore, we have not seen any increase in admission and even a decrease in admission in psychiatric hospitals, particularly in 2020. Also, people didn't want to go to hospital at that time. But if you had a psychiatric disease and you were getting really feeling very bad, I mean, you would have had ultimately to go to the hospital. So it seems that truly in 2020, things went actually better than thought. And there are some tentative explanations for it. Things changed in 2021, particularly when the control measures seemed to be continuing and nobody had an idea when they would end. And if you have to remember one population which has suffered from this crisis, and that is seen in all industrialized countries, it's the population of adolescents. The only places where you see a clear signal of mental suffering is with adolescents, and particularly female adolescents, where you have an increase in the proportion of suicide attempts among admissions in hospitals, and you also have an increase in eating disorders, particularly anorexia. What is interesting is if you look at the data from the US, this trend had started in 2010. So it predated the COVID-19 pandemic, but it accelerated with the COVID-19 pandemic. And all those observatories I was mentioning on psychiatric disease worldwide have documented this increase in suicide attempts and anorexia among female adolescents. Male adolescents did actually reasonably well. For children education, the estimation is about a loss of a trimester of schooling in industrialized countries during the pandemic time, and 2 trimesters of schooling for medium-income countries. We don't have an estimate for the low-income countries. And finally, economically, there are not many figures available. I quote here one data coming from the IMF, estimating a lost GDP output of $12,500 billion for the period 2020-2024. For France, the only estimate I could see from the government was given by Olivier Dussopt when he was Minister of Public Comptes Publics. I'm not sure how to translate that in French, but I mean, you figure it out. And he said that there were an estimated 424 billion euros lost during the period 2020-2022. Other estimates I have seen from France range between 200 and 500 billion euros for this period. So it's a large interval, but we are talking about a few hundreds of billion euros for that period. Now, the question is, will this happen again? And here, unfortunately, the picture is not very optimistic. What you can see here on this slide are the different emerging infectious disease over time, covering a period starting in the end of the 20th century up to now. If you look at the last 40 years of the 20th century, there were about 5 what we called emergence of infectious disease, with notably AIDS, which was a major crisis, as you all know, for the 20th century. However, if you look at the first 20 years of the 21st century, we have already had 10 emergence of viruses, also some bacteria in between. And this really looked like an acceleration of this phenomenon. It's not a matter of better detection, because we all today have better surveillance over the world, or we have better diagnostic tools, because all these emergences would have been noticed anyway, because they had a major impact. It could have just been diagnosed later, but it would have been seen. And if you look particularly at SARS in 2003, the pandemic flu H1N1 in 2009, Ebola in West Africa in 2014, Zika in Latin America in 2015, and COVID-19. I mean, these were major, significant, impactful emergence for the beginning of the 21st century. And we do see an acceleration of that. And the pictures you can see at the bottom of these slides, I mean, are explanation for it. I will come back to that a bit later, but it has to do indeed with the increase in the population density, in the population mobility across the world. It has also to do with our contacts with wild animals, and I will explain why later on. It has to do also with the industrial farming of pigs and poultry, which are incubators for new viruses. And unfortunately, all that is going in the wrong direction, and therefore we have to be ready for new pandemics, as this is just not, COVID-19 was just not an accident, I want to say. It's really something that is going to happen again, and we have to be ready for it. For that reason, I think it is important to look back at COVID-19 and try to find out, among the experience of different countries, what we can learn there, and what could be done next time if a new respiratory virus emerge and is as threatening as COVID-19 was. If you look at the strategies that country has followed, you may identify 5 different strategies for the response to the pandemic. First one on the top left is what we call herd immunity. Basically, we know for any epidemic phenomenon that when a certain proportion of the population is infected, we reach what we call herd immunity, and the virus stops to circulate in an epidemic mode. And therefore, the strategy there was to let the virus circulate in the population, controlling it so that the hospital would not saturate. And then you reach this herd immunity level so that the virus stops circulating. And in between, you protect the very old people, those we knew were very vulnerable for COVID-19, so that they don't get harmed by the circulation of the virus, which mainly takes place in the younger communities. But this way, you do manage to reach a level where the virus will stop circulating in epidemic mode and without too much affecting the functioning of our society. Another strategy opposite to that is what we call zero COVID. And zero COVID is really zero tolerance with the circulation of the virus. That strategy has been used by countries which could very well control the entry of the virus. These were islands like Australia, New Zealand, Taiwan, but also continental countries who could put in place measures that would be very restrictive to the population to prevent the circulation of the virus, and that was China. And here, if I take the example of Australia, they control very well the entry. So there is a very large decrease of the number of people who can go to Australia. I mean, they, for instance, stopped the family reunion for a couple of years. Those who come to Australia will have to stay in quarantine hotels for a period of 2 to 3 weeks. They are tested repeatedly, and when you are sure that they are negative for the virus, you let them go into the population. And if in a city you detect a few cases, basically you close that city for a period of 3 weeks. You test intensely around the few cases that you have identified, and you reopen the city only when there is no longer any circulation of the virus. So big cities of Australia, like Sydney, Melbourne, for instance, could go through 3 or 4 lockdowns during the first 2 years of the pandemic. During this period, these 3 weeks of lockdowns, they were exactly as we were in Europe, in France, when we had those lockdowns. However, when the lockdown was over, then people could live perfectly normally. You no longer had any restrictions. So you had, let's say, a perfectly normal life for most of the period of the 2 years, the first 2 years of the pandemic. However, you had short periods of lockdowns when viral circulation had been detected. There is a softer version of the zero COVID, which is built around very aggressive tracking and tracing. This was performed by Korea and Japan, particularly Korea, who could use very sophisticated digital tracing through your smartphone to know exactly the places you have visited, and therefore be able to find out who might have been in contact with the virus or not. For a period of a couple of years, because they control very well the circulation of the virus, in a country like South Korea, they had maybe only 50 cases per day. And for the 50 cases, looking at their smartphone, they could tell where all the places the people had visited in the 5 days prior to being diagnosed with SARS-CoV-2. And they could look at all the trajectories of those people during 5 days and see who else they had eventually met in a store, in a shopping mall, in a restaurant, well, in any public place, basically, and inform the people they had met with a message saying, you have visited 2 days ago a place where someone has subsequently been diagnosed with SARS-CoV-2. You might yourself be infected. Please stay at home. And when I say please stay at home, this sort of confinement was also associated with very strict measures. If you were violating this order of staying at home, $8,000 fine and possibly 1 year of jail. I don't think anyone has been put in jail, but that was part of the measures that could be taken. Where they were really good is that doing so, they were in fact stopping transmission chains far before the obvious diagnosis or the exact diagnosis of the person, and therefore they were efficient in controlling. If I compare to what was done in most of the rest of the world, where people waited to be symptomatic to be tested, it takes another day, then the health authorities are informed, then they start to ask you for your contacts, and then they inform your contacts. It may take 2-3 days after people had symptoms before their contacts are informed, and already the infection had taken place and it was too late to stop the chain. But because of this smartphone tracking performed by the South Korean, they were really efficient in cutting the chains much earlier, and it worked, whereas it did not work well in most of the rest of the world. Now we move to strategies to the right of these slides. On the top, the stop and go. Stop and go is basically what most of countries in Europe, for instance, have done, what the US have done, where basically you let the virus circulate. When you reach a level of saturation of the hospitals and intensive care unit, you put in place lockdown for a period of time of maybe 1 month or 6 weeks. Cases go down, including in hospitals. And when the circulation is low again, you reopen. And then it will gradually build up and reach again a stage where you will have saturation of hospitals, You put again a lockdown, you wait until it goes down, and you alternate periods of go where the virus circulates and stop where you put lockdowns throughout the time of the pandemic. And this is what most Western European countries have done, for instance. And the last strategy, act early and hard, meant that whenever you had, you could see that the epidemic was taking off, you would put in place measures to control the circulation of virus much before you reach any saturation of the hospital. You do that very early in the course of the rising of number of cases and hospital admissions. And this way, you prevent hospitals to be filled and you can reopen much earlier. So you had also tough measures, sometimes close to lockdowns, but you take them very early and therefore you can stop them very quickly and you have shorter lockdowns compared to other countries. So now let's look a little bit at what happened in different parts of the world where those strategies were used. But first, I will take you to the situation that we faced in France at the time of the first wave. And what I will share with you are data that the Imperial College had prepared for modeling for the situation in the UK, knowing that the UK had a population very similar to that of France in terms of size, in terms of age distribution, and also similar health system, and particularly same number of intensive care units. So for those of you who know France, you may remember that the scientific council to which I belonged had been called by the government on March 11, and we knew that we would meet with the president, Emmanuel Macron, the day after, on March 12. And we had to come and to make some recommendations one day after to the president. And we had very little data available because the surveillance systems were completely broken down because of the intensity of all the work that the public health agencies had to do. They were just overwhelmed. And therefore, we had to rely on modeling. And the slide you can see here is a modeling that the Imperial College had prepared for UK. And they shared it with us on March 11, knowing that it was going to be published on March 16. And what you see here are the occupation of the critical beds, well, beds of intensive care units for the UK. And what you see in black is a curve, an epidemic curve of the critical care beds occupation for UK in the absence of any measure, what they call do nothing. And then you can see all the other curves where you do take some form of measures with case isolation. You can add a household quarantine. You can decide to close schools and universities. You can also try to protect the more than 70 years of age. And you do see that you can flatten the curve. I mean, there is decrease about threefold of the peak of the curve when you take maximum measures as described here. But what is important is this horizontal line. I don't see if you can see my arrow here, but it is the one here which is anyway pointed by this arrow, which is the maximum ICU bed capacity of the UK. And they have basically the same number of beds as France. And what you can see is that whatever you do, you are going to be totally overwhelmed. And therefore, you have to take measures very urgently. And our colleagues from UK conclude that epidemic suppression is the only viable strategy at the current time. And that also applied to us. Basically, we were exactly in the same situations as the UK. And you may find in the opinion we wrote on March 12, the recommendations we made to the French government. They are all available on the site of the Ministry of Health. Still, I mean, what we were telling the government basically is you need to decrease by at least 60% the contact of the people if you want to control the spread of this virus. Lockdown works. We saw it in China. But we also said maybe some other measures would work, provided the population adhere to those measures. I mean, the population is compliant with those measures. And the choice between the two is a political choice. And this is what we the way we proceeded with the government, which is basically to give them alternatives and to let them decide. I see a question on what ICU means. It's intensive care units. So it's critical care, if you want. In French, réanimation ou soins intensifs. I don't know if that explains, but basically it is the place where the people who are in most respiratory distress are sent for mechanical ventilation. And basically, if you cannot get to intensive care unit when you need to go there, you will unfortunately die. So you can see here on these slides how tense the situation was at that time. And the unthinkable happened. For France, it was on March 17, and for most of Europe, it was in the same week that all countries took those measures to stop the circulation of the virus. You have to realize that such measures had never been taken in the history of humanity. We had isolation, we had quarantines, we had people, let's say what we call in French, cordon sanitaire, people who were not allowed to leave a city, but they could move freely inside that city. But we never had a stay-at-home order or lockdown like happened here, not only in France, but in many other countries. And that was absolutely unique. So this was really measures very difficult to take. But when you look at the modeling graph that I was showing you earlier, you realize that there was not many alternatives, at least for countries where intensive care units were already close to saturation. Now, we are going to visit a little bit of Europe and see what has been done by most countries who dealt with this epidemic in Europe. The indicator I am choosing here to evaluate the impact of the pandemic is excess mortality. So it's a number of deaths that took place in excess of what was expected for the period 2020-2022 or mid-2022 on this graph. Why excess mortality? Because these data are easily available in the sense that mortality data in industrialized countries are available quickly. We all agree on the definition of alive and death, whereas we not all agree on the definition of died because of COVID or died with COVID. And COVID also had indirect effect on mortality. If you have a saturation of your healthcare system, some people will have to delay some care for cancer, for instance, or some important surgery, and therefore they may die of it. And opposite to that, because of measures which were taken like lockdowns, the circulation of other respiratory viruses decreased during that time. And you did not have, for the year 2020 and 2021, the 10,000 of people dying of flu in France, for instance, every year, because all the circulation of the flu virus was stopped with the measures. So you have also some beneficial effect. Some people stopped doing their jogging and therefore stopped doing their heart attack. There were less car accidents as well. So you see there were some negative effects, but there were also some positive effects with the measures. And excess mortality basically is a way to take all this into account. On the top of that, you have long effects of COVID-19. I talked to you about the long COVID itself, but we know now that people who did a mild COVID infection still have, for the year following that COVID infection, a 30% increase in the risk of heart attack or stroke. So all that has to be taken into account in our calculation. And the methods for calculating excess mortality are well known. They have been developed for looking at flu and the impact of flu, and we could apply them quite easily for looking at the impact of COVID-19. So we also had methods available. What you can see on this graph basically is that during this period up to mid-2022, the Scandinavian countries did very well, together with Ireland, which is an island. Then you had a series of countries ranging from basically Germany to Spain, with varying levels of mortality, increasing particularly for Austria, United Kingdom, and Spain. And you had Italy, which was really on the top. And I just put United States for comparisons here, with much higher excess mortality. Some of it may have to do with the fact that the population of Italy is older compared to the rest of Europe. They have 7% of people more than 80 years of age compared to only 3.5% for Ireland. But we did those graphs with adjustment for age, and it does shrink a little bit, but not so much. In fact, I mean, there are other reasons why Italy, unfortunately, suffered such an excess mortality compared to the rest of Europe. But now going back to the different strategies which I explained, let's look at the stop and go, which is what most of Western Europe did, and particularly the countries that you can see here. And there, indeed, you see now that we have Ireland, which, as I already mentioned, did a little better. They were very strict very early in the end of 2020, particularly in the management of the epidemic. They did take quite tough measures, but it paid out. And also being an island, it helped them a little bit. You have a group of countries like Switzerland, France, and Germany that come together, then the other countries mentioned earlier, and Italy with a large excess death. We have not sorted out exactly what could make such a difference between, for instance, France, Spain, and Italy, which are countries that have similar population size, roughly, but also very exposed to a large number of tourists visiting those countries, for instance, large influx of people. But it's clear anyway that this strategy had this negative effect of with the hospital filling, making a lot of time to clear them, and a sort of a vicious cycle where countries were just struggling with very large number of hospitalized patients and the economy suffering from it. Now, the herd immunity, which is something that has been praised by many, and particularly looking at Sweden. And I do remember of a lot of my colleagues asking me, but look, Arnaud, what happened in Sweden? Why didn't we do the same in Europe? What I think is important is to compare Sweden with their neighbors. And here I have put Finland, Norway, and Denmark. And what you can see is that during the first year of the pandemic, actually Sweden was much higher than the three other countries, Scandinavian countries. And if you were to compare with France, Sweden had a 50% higher mortality compared to France. So actually the first year in Sweden has not been easy. In the end of 2020, well, what the Swedish did is their public health officer really tried to put in place this herd immunity strategy by saying, we are going to take some measures. We are going to ask people to be quite disciplined, but they, for instance, left the bars and restaurants open, left most public places open. They were just asking people to be vigilant, and they tried to isolate the older people, the more than 70 years of age, but unfortunately that did not succeed. And the virus finally hit the older people in Sweden, and this is what explains this very high mortality they experienced, which again was higher than the one we have had in Europe, in France, for instance. In the end of 2020, the king went to TV, the prime minister as well. The king of Sweden was in tears, and they said, we apologize in front of the country for mismanagement of the pandemic. They fired the person who was in charge of the public health policy for the country, replaced by other teams, and started to apply what other Scandinavian countries had put in place. And from that time on, they did very well. As you can see, the excess mortality almost did not rise. And they did reach, they vaccinated extremely well. So Sweden could have done as well as the other ones, but they had this first year, which is considered by the Swedish at least as a failure. What you see here for the other countries is that they are negative in the first year of 2020 for excess mortality. And that has to do, as I mentioned, with the fact that they stopped the circulation of other respiratory viruses. So they did not have the deaths of flu, for instance, that usually is experienced by those countries. Now, one country which I think did extremely well is Denmark. And here you can see the excess mortality curve of Denmark throughout the pandemic. negative up to 2022, and then a slight rise in mortality, but as you can see, not that high. What did the Danish do that others did not do? Well, first of all, I mean, Denmark is run by a government led by a woman, Mette Frederiksen. And if you look at the 5 countries who best managed the COVID-19 pandemic, 4 out of the 5 are run by women. I'm talking about New Zealand, Taiwan, Finland, and Denmark. So maybe there is something in the relation to risk for women that is different than for men. Not going to speculate on that. It's a very low-level psychology that I'm doing here. But the fact is that in those countries, I mean, the epidemic has been handled very well. What Mette Frederiksen did, which is interesting, is that she went to TV on March 11. At the time, there were only 10 people hospitalized in Denmark, and most were hospitalized not because of the severity of disease, but just because they had SARS-CoV-2 and they wanted to put them in isolation. So it's a country of 6 million people, but only 10 hospital cases, and most of them very benign. And that was enough for her. And talking with the modelers of the SSI Institute in Copenhagen to say to the country on March 11, you see nothing right now. There are virtually no people in hospitals. And still, I'm going to ask you, starting from tomorrow, to stay at home. Because if we don't take some measures, we may, in 3 to 6 weeks from now, be in the same situations as Italy. And you all remember that Italy, by the end of February, went into this nightmarish situation in the northern part of the country. And what they were saying is do teleworking as much as you can, which about 50% of the Danish people could do. We close the schools, we close bars and restaurants. But what was interesting is you can go out as much as you want. They did not have those permit, to go out like we had in France, where you were allowed to go out for 1 hour. So just said to people, you can go out as much as you want. But if you meet people in the street, speak at a distance and don't gather, don't make large groups, and come back home in the evening. Don't go to other people's place. And as you know, there is a certain culture of public health in Scandinavian countries. People are quite well disciplined. They listen to her advice. They did have a little peak in hospitalization. These were the people for 11 days that were already infected at the time she talked, and that were to develop the infection, the disease, and hospitalization for those who had were meant to have a severe form of disease. But after 11 days, it went down, and the level reached during the first wave was much lower than the hospital admission levels that most of European countries had. It's about 3 times lower, and for a very short period of time. They could actually go out of this stay-at-home order, which was a relatively mild one, 1 month earlier compared to the rest of Europe by mid-April. And they did the same in the fall. With Christmas, they had a larger peak, but again, it was for a short period of time compared to the situation of most European countries where admission level in hospitals are much larger. And then it went down. When vaccines were available, they immunized very well. And then with the Omicron wave in 2022, they just let it go. They did not put any measures. They just asked people to be disciplined, but they did not put this stay-at-home order again. And they did reach a large peak, but it was hospitalization for people who were already immunized. And because they were already vaccinated, they did not have forms as severe as in the absence of vaccination, so that the increase in mortality, as I was showing earlier, did go up a little bit in that time, but not reach anything compared to other European countries. So these very early measures taken by Denmark were really a very smart way to look at it. But for that, you need a very high trust in your government, because if you are told stay at home when the hospitals are still empty, if you follow those recommendations, it means that you really trust your government and institutions. And I show you here a map of Western Europe with a correlation between trust in government, which is going on this scale, and high trust of government here, and the cumulative excess mortality in 2020. And you see that countries where you had the highest trust in government are the countries which experience the lowest cumulative excess mortality. What is interesting also when you do this approach of taking measures very early is that if the measures that were recommended at that time were not sufficient, after 2 weeks, if it had continued to go up, they could have tightened it a little bit more, until they finally get it down. Whereas if you wait until your hospitals are completely saturated to take the measures, you have no other options than just to break as fast as you can, and therefore to take measures that sometimes are exceeding what you really need. So these very early measures also have the benefit to give you a chance to calibrate your measures if you realize that the first measures you propose are not strong enough. Now, moving to South Korea and Japan, I remind you that South Korea particularly did practice this very aggressive tracking, using smartphones to inform people that they had been in contact with someone that might have been infected, and therefore you stay at home. Worked very well until Omicron arrived. And they managed to control the circulation of the virus, keeping all public places open. They were using a lot of masks, particularly in Japan, and people were very compliant to the wearing of masks, but they keep everything open, and this very aggressive tracking with smartphones worked well. When Omicron came, Omicron being more transmissible than previous variant of SARS-CoV-2, you did get this peak of cases that you can see here, with BA2, which was one variant of Omicron in South Korea, and BA5 a little bit later on for South Korea and Japan. When it comes into mortality, it's at that time that they started to have rise in mortality with those peaks of Omicron. And basically, the take-home message here is that this very aggressive tracking using smartphones worked with the initial versions of SARS-CoV-2, but after a while, with more transmissible variant like Omicron, and a little bit of pandemic fatigue in the population, they were no longer able to control the circulation of the virus, but the impact, fortunately, has been relatively limited if you compare to France, for instance, because population had been immunized by that time. Now, if you look at zero COVID, what Australia, New Zealand, and Hong Kong did, what you can see here is Hong Kong, New Zealand, Australia, the number of cases. Again, zero COVID worked very well with previous variants of the SARS-CoV-2. When Omicron came, more transmissible, and again with the pandemic fatigue, they did not manage to control. It started to circulate very fast, and Hong Kong particularly had a huge peak in March 2022 of an Omicron variant, BA2. What is interesting is that when you look at the impact in mortality here in this graph, you see that you did not experience any impact on mortality in New Zealand and Australia, but a huge peak of mortality in Hong Kong. And the reason for it, you find it in the right side of the slides. When you look at the boosters administered per 100 people, so the third injection for the vaccine, it was higher in New Zealand and Australia compared to Hong Kong. But what was particularly surprising in Hong Kong is only 10% of the population aged 80 years or more were vaccinated. So where Hong Kong failed was vaccinating the 80 years and more. And they explain this because zero COVID working well in Hong Kong and being afraid of potential side effects of the vaccine in the very old people, they did not immunize their very old population. But unfortunately, when Omicron came, the population of 80 plus was poorly vaccinated, and they had this huge peak of death, similar to what New York and London experienced in the first wave of the epidemic. So something really massive. And it's just a pity that they had not properly immunized their population by the time that those viruses circulated. Also interesting here is many of you have the feeling that Omicron is a mild variant of SARS-CoV-2, but not at all. It has been mild in many of us because we were already immunized or we had already been infected by a previous version of SARS-CoV-2. But in places where the virus circulated for the first time, where zero COVID had worked well before, like Hong Kong, when Omicron came, it has exactly the same severity as the very initial virus that came from Wuhan. So if you do this zero COVID policy, it's very important that you immunize your population at the time the vaccine is available. And pretty much the same happened in China, mainland, where they had not sufficiently immunized the very old population when they lifted the measures in November 2022, and they experienced a peak of mortality for which we don't have any robust data, but we estimate was something between 1 to 2 million deaths when the virus started to circulate after they lifted the measures in the end of 2022. Now, to conclude this first part of the talk, I have heard a lot. People telling me, well, be very careful with the measures you are imposing on population because those control measures will impact the economy very badly. But if you look at this ecological correlation, and I agree that it's not very high level of evidence, still what you can see here is the excess mortality on the x-axis and the GDP growth on the y-axis. And basically, the countries which had the larger excess mortality are those who suffered the larger GDP loss, and the countries which has the lowest excess mortality are those whose economies work better. And these were countries which implemented measures very early and quite hard. So, in fact, implementing measures very early and hard will save lives, but also preserve your economy, contrary to the expectation that it would damage the economy when you compare it with countries who let the epidemic go. Now, for the second part, which will be shorter of my talk, I'm going just to tell you a little bit about the future threats and the risk of future pandemics. How do these new viruses emerge? Basically, these are viruses coming from the animal world and crossing what we call the species barrier going to humans. So basically, you have a virus living in an animal reservoir, which is going to be a wild animal, not much in contact with humans, a bat, a migratory bird, a rodent. And to get to humans, they usually go through intermediate hosts who have contact with humans, which can be farming animals like pigs or poultry, or chimps, which are hunted in Central Africa, or civet cats, which are part of the meals in restaurants of exotic food in China, for instance. And so from these wild animals, the virus will come to those intermediate hosts, and they're reaching human populations, sometimes through a mosquito vector. And the next step, which is very important, is whether it will become transmissible from humans to humans. And if that new virus coming from the animal world becomes transmissible from humans to humans, you have a risk of an epidemic and then a pandemic. So briefly, if you look at SARS 2003, for instance, you had a reservoir, which was a bat, in a rhinoceros bat. Intermediate host were the civet cats eaten in the restaurants of Guangdong, and then humans here. If you look at Ebola, again, a bat, chimps of Central Africa and gorilla, which are the non-human primates who can be infected with the Ebola virus. Humans are hunting those animals, and then it can get to humans. And now with flu, you have migratory birds and aquatic birds as reservoir, poultry and pigs at intermediate host, and eventually transmission to humans. So this is the sort of cycle that we can see. If we really concentrate on the main threat, I would put on the top of my list respiratory viruses for the reasons that I gave you earlier about the perfect storm of COVID-19. What we have at the beginning of the infections with beta coronavirus are a reservoir, which is a rhinoceros bat, you can see here, also called a horseshoe because of this shape of its face. And these bats harbor many coronavirus, and we were able to identify the closest one from SARS-CoV-2 in the southern part of Laos, in a work performed by a colleague of Institut Pasteur of Laos together with us in Paris. And eventually, this virus will move to humans. We know for SARS in 2003 that it came through a civet cat. We do not know for COVID-19 how those viruses came to humans, but we believe that the wild animal markets called wet markets play a very important role because in those markets, you have a lot of animals who can carry those viruses and transmit them to humans in the markets. And in this survey of China in end of 2021, 2 years into the SARS pandemic, or the COVID-19 pandemic, sorry, still many markets of China were open and with many animals that are susceptible to transmit the beta coronavirus to humans. So it's really important that we work on controlling those markets, also on fighting deforestation, because the habitat of those bats can be moved because of deforestation, and bringing those bats to contact to other animals and eventually further transfer to humans. Influenza virus are another of the major threats. And just here, a slide to explain to you how new influenza virus are generated. If you look at the 1918 Spanish influenza, it came from an aquatic bird to humans. And here is a virus that was responsible for this grippe espagnole, Spanish influenza in 1918. The next pandemics of the 20th century came when this virus, H1N1, came in contact with another virus, H2N2, from a bird. And here you have a process of reassortment of genetic material, because the genetic material of the influenza virus is made of 8 segments. And here, provided that you get a new gene coding for the hemagglutinin, which is a surface protein of the influenza virus, or the neuraminidase, another surface protein, you get around your virus new proteins which the immune system cannot recognize. And because it cannot recognize it, then you become susceptible to this new influenza virus and you have a pandemic starting. And that happened with H2N2 in 1957. With H3N2 in 1968, we are just wondering which one will be the next one. In fact, in 2009, this slide is a bit old, we had a new H1N1, a little bit change here, that spread throughout the world. And now we are really concerned about the risk of a new influenza virus, which is a combination of H5 and N1, so-called H5N1, eventually reaching humans after it would have circulated most likely into farming areas, where in those animals you can have a lot of combinations and adaptations of the virus to mammals. And when adapted to mammals like pigs, or here it's minks and the vison in French, then you can easily go to humans. And we are currently very concerned about H5N1 virus circulating in the cows of the US and giving very high concentration in their milk. That virus will reach Europe probably in the fall, and getting into contact with mammals like it is currently do with the cows. It eventually may adapt and eventually may turn to transmission to humans. So we really need to be ready in case this new H5N1 would pop up into human population. The good news about influenza is that we know how to do vaccines, but it would take us 3 to 6 months before we can get the capacity of vaccine production that would protect reasonably well our populations. The economics for pandemic prevention, is taking a little bit into account what I was just mentioning earlier, the issues of monitoring the wildlife trade, the early detection of control, also the farming animals, livestock, limiting deforestation because it perturbates the habitat of wild animal, and ending this wet market of China, which has a cost of $20 billion per year. You see that it's quite high. There are some ancillary benefits, because with stopping deforestation, you get some benefits with your CO2 emissions. But basically, you do not balance. But what you have to put on the other side of the balance is the cost of a pandemic, which here was estimated for COVID-19 at $11.5 billion, very similar to the figure I gave you earlier. So basically, there are ways that we can try to counter those epidemic, but you can see that the costs are huge. Investment would be huge at the start. One word about mosquitoes, because it's important that you realize that there are some viruses transmitted by mosquitoes like dengue, Zika, chikungunya, and yellow fever. And we nowadays have new ways of controlling these viruses into mosquitoes, which goes by infecting mosquitoes with a bacteria called Wolbachia. And this infection gives a reproductive advantage to the Wolbachia infecting mosquitoes, but also they cannot be co-infected with a virus. So if you just disseminate a population of mosquitoes that have been infected with Wolbachia in those form of farms of mosquitoes, and you disseminate them in the environment, they will replace the original population, and they cannot be co-infected with a virus like dengue, for instance. And that has been experimentally tried in Indonesia in a very large randomized trials, where some areas were dedicated to mosquitoes that were infected with Wolbachia and could not be co-infected with dengue, and others were the control areas, like you can see here in light gray. And what you can see that when they disseminate their mosquitoes in the intervention areas, they quickly reach 100% of the population of mosquitoes. And there was a bit of contamination in the control areas because the mosquitoes could fly from one area to another one. But interestingly, they were able to decrease by 80% the risk of dengue infection for the people living in the areas where these Wolbachia-infected mosquitoes were launched. A quick word on the impact of climate and environmental change. A slide, and all my slides will be available to you on request. I left them to Zing and Philippe, so you can just ask them. This one is just to tell you that there are many potential mechanisms by which the effect of climate on warming, precipitation, floods, drought, etc., will in fact different transmission of viruses, whether it's vector-borne, waterborne, airborne, and potential disease shown here with whether they belong to viruses, bacteria, and etc. I'm not going to detail these slides, of course, but there are many mechanisms by which it could happen. A few modeling exercises have been performed to try to find out whether climate warming would increase this sharing of viruses between species. And the bottom line is yes, over time, in a period of 50 years, we expect that there will be more and more viral sharing events among mammals because of the climate warming, mammals will have to move to higher elevation area and meet new animal species and exchange viruses. I will not go into the details of those models. My concern is that they treat all viruses equally, whereas for me, it makes a huge difference if you are talking about a virus like a beta coronavirus that can give disease like SARS or COVID-19, or whether you are talking about some viruses that have never been harmful to humans. And the problem of those very large exercises is that they just consider all viruses being equal. There are about 10,000 viruses living here in animals that could eventually infect humans, but I would not weigh them all the same way. Likewise, if you consider that the animals may not be moving the same way, whether they are terrestrial or flying, because there are some terrestrial barrier. If you only consider the flying animals like bats, it's really in Southeast Asia that most future emergence will take place according to this modeling. And here they did an exercise with Ebola and show that they expect within the next 50 years that there will be 13 new animal species that could be infected with Ebola because of this, and that this will happen more in the eastern part or western part of Africa compared to Ebola currently being in the central part of Africa. Again, I'm going a little bit fast through those slides because they are pure modeling exercise on which I have some reservations, but you can find the papers and get into the details of them if you want. One work which is a little bit at the opposite, very detailed, is work done by teams in Australia, where they spent 25 years looking at an area of maybe 50 kilometers square, and where you have some bats living in the forest. And because of the deforestation, those bats were leaving their forest habitat to get to agricultural areas where they can get into contact with horses and transmit them a virus, Hendra virus, which eventually can get to humans and give encephalitis. And here is a very detailed study between those forests, the bats, the effect of deforestation, the moving of the bats to different areas, agriculture and urban, and the spillover of the virus from the bats to horses, which takes place, you see, more commonly now in the recent years compared to the earlier time of the study, and particularly during the winter, which is in Australia from June to September, when the bats have to go outside of the forest to get some food. So you can have those very detailed work showing you the impact of deforestation on the ecology of bats and the transmission of the virus to horses and eventually to humans. And now with climate warming, we all think of mosquitoes. We mentioned already the arboviruses, yellow fever, dengue, Zika, and chikungunya. They are carried by mosquitoes called Aedes aegypti, you can see here, and Aedes albopictus, which is a so-known tiger mosquito. Aedes aegypti lives in tropical areas, mainly in very large suburbs of those very big cities of tropical areas. And Aedes albopictus is present there, but also present in temperate zone, and it is the one that is now moving northward in Europe. And we have all heard of the mosquito tiger. And actually, yesterday we had the first case of dengue transmitted by an Aedes albopictus in France locally for the year. So this is just telling you that in this modeling with climate warming in 2050, we will have longer time periods, and it will be all year long from many parts of the world where all those viruses can be transmitted because of the climate warming. And in Europe and in the US, it will become significant. We will have periods of 2-3 months during which all viruses will be transmitted locally in the future, in the next 20-30 years. To finish with this part, just to say that there are not only viruses which are concerned by these emergence, but there is a disease, cholera, which is also becoming more and more common, and it has to do with the climate warming. And here you have an interesting modeling exercise showing you that the El Nino oscillations that take place in the Pacific area result 6 months later in warming in northern Bangladesh, and 5 months later in higher temperatures in the water of the southern part of Bangladesh and rise in cholera. And if you shift by 11 months the El Nino oscillations, you can see that they match very well with the cholera outbreaks of Bangladesh. So it's really something happening at two very different, distant parts of the globe, where with an 11 months delay, the El Nino oscillation translates into cholera outbreaks in Bangladesh. Now we are all concerned about these new viruses, that we have never seen, what we call the unknown threats, the pathogen X. And just to tell you that the lessons that we have had of the past 20 years is basically we were unable to tell and predict where the next emergence would take place and when it would take place. And I have given you here places where we had emergence of viruses totally unexpected. It started with SARS in 2003 in Southeast China. But who would have thought that MERS would start in Gulf countries with a virus pretty similar to SARS in 2012? The chikungunya would leave eastern part of Africa to go around the world in 2005. That we would have an epidemic of pulmonary plague in 2017 that we were able to stop, but could have been very damaging. That Ebola, which is usually in center of Africa, would move to West Africa in 2014. Zika would leave Southeast Asia to travel Pacific and get to Latin America in 2015. That Mexican flu would start not in China, but in Mexico in 2009. And that monkeypox, who is a virus of Central Africa, would end up in the Canary Islands and then Europe and the rest of the world 2022. We are just not able to predict, and therefore we have to be very reactive with all those emergence and act very quickly to stop those new outbreaks. What we are doing in anticipation, though, is working at the frontier with some animals that we know can be very much carriers of future viruses, particularly bats. And we have programs with bats where we look and discover viruses by taking samples from bats and amplifying in sequencing all the new viruses and studying whether they can get into human cells, whether they can multiply, whether they can bypass immunity, and whether we can detect antibodies in population living close to those bats, which would tell that the virus is already circulating. And we can do all of that in very safe environment using what we call pseudotype viruses, so that there is absolutely no risk of further infection because these are fake viruses that are used for experiments and cannot be infective to humans. What we also want is to be ready to react in case of a new pandemic, and we are currently building some operational networks of detection, studying, sequencing the virus, looking at the transmission, and modeling the spread of those viruses. So all those different steps are currently being established because we know how to be reactive in case of a new pandemic. And we are also working on future vaccines for those threats because we realized that we cannot develop a vaccine during the time frame of a pandemic. It's too short. It would take too much time for developing a new vaccine. So what we do is that for viruses which are known threats for future pandemic, we work on vaccines ahead of time, and we bring them to what we call phase 2. So basically, we develop the vaccine, we test it in humans to see whether it is safe, we test it in humans to see whether people vaccinated can develop antibodies, and we keep it on the shelf if we know the vaccine is safe and can stimulate production of antibodies. And the point is, if an outbreak starts, then we are able to build up this capacity of vaccines to do the phase 3 trials, to look during the epidemic if the vaccines is really protective, and we save the time of the phase 1 and 2 development, which can take a couple of years. And there is a public-private partnership to ensure that for all those viruses, we would have vaccines ready to be deployed would an epidemic start. And my last slide is to tell you that it's really important to invest into basic science, because although we want to have those tools like diagnostic tests, treatment, and vaccines readily available, it can only come with basic science. And Pasteur, the institute where I work, has been very much criticized because we did not develop a vaccine during the pandemic, the COVID-19 pandemic. But first of all, you have to realize that we are not vaccine producers. People were confusing the institute where I work, which is doing basic research, with Sanofi Pasteur, which is the company which is marketing vaccines, you know. But anyway, what Institut Pasteur did was to discover mRNA in 1961. This is really basic science. And we had François Gros and François Jacob, who were in the teams who identified 60 years ago mRNA. But we have to thank those people that you can see here on these slides for being incredibly reactive at Moderna and BioNTech in developing the vaccines for SARS-CoV-2. What you may not realize is how quickly this happened. If at the time our Chinese colleague posted the SARS-CoV-2 genome on site, which was the 10th of January, it took only 1 day so that at Moderna, they inserted in the mRNA the 2 mutations they had identified to stabilize the spike protein. And that was 10 years of research on the MERS coronavirus vaccine. And it took only 5 days before this mRNA, transformed with these 2 mutations, was encapsulated into lipid nanoparticles to protect it from the site of injection to the cell. So 5 days only to develop the vaccine. From there, it took 2 months to produce the vaccine for the first clinical trial, the phase 1, and another 2 months for the dose for the phase 2. And then in July, they could start the phase 3 trial. So the vaccine was in fact developed in only 5 days, but then you need to produce it large scale for the trials in humans, and later on, when proven efficacious, for the use in the human population. And thanks to the vaccine, we probably avoided 2 lockdowns compared to what we would have needed. And these would have been the 2 lockdowns that the population would not have accepted, I believe. And as I said earlier, 25 million lives were saved. So this is it for what I wanted to tell you. Sorry that I've been a bit long, but it's always very difficult to keep time when there are so many things that I want to share with you.
No, thank you very much, Arnaud. It was a fascinating presentation, and therefore not too long, because of course we discovered and learned a lot by listening to you. It's very, very, very fascinating.